Yeah, Jean, thank you very much for the kind introduction. It's a great pleasure to be here again at the Mayo Charité and to be part of a debate, and I should play the role for open surgery. I have no conflicts of interest to mention. So what we dream on is that we see this evolution of surgeons now sitting down in the robot, and we dream that we don't need anymore those large incisions. We can do it laparoscopically. Actually, today in the morning, we already discussed for a radical hysterectomy, we don't need this large. We can also do this by a smaller incision. This is also working without these huge incisions. So, but coming back, why should we do a minimal invasive surgery for a radical hysterectomy? First of all, if we have a better oncological outcome, at least we should have the same one. But when we look what has been published, the LAAC trial 5 years ago clearly demonstrated inferiority of the results. And this has been confirmed by a meta-analysis. 15 studies clearly confirm that minimal invasive surgery was associated with an elevated risk of recurrence and even death compared with open surgery. And Pedro Ramirez presented last year the final results of the LAAC trial. And indeed, you see that the disease-free survival is clearly inferior. So it's a hazard ratio of almost 4. Progression-free survival, hazard ratio of 4, inferior for microinvasive surgery. Disease-specific survival, it's 2.6 times higher if you're doing a minimal invasive surgery. Cumulative local or regional recurrence rate, again, almost 5 times higher if you're doing a minimal invasive surgery. And the most critical point in the end of the day is overall survival, a hazard ratio of 2.7 is the risk that the patient will die because you are choosing the wrong approach. There has been also some exploratory analysis. Maybe we are looking for the wrong tumors, large tumors larger than 2 centimeters, hazard ratio of 4.25. But even in the smaller tumors, you see there seems to be a difference. This is exploratory analysis. You cannot put any p-values there. And this has also been confirmed. A recent meta-analysis by Dimitrios Nasiodis. Again, you see 10 studies. Also for those tumors less than 2 centimeters, minimal invasive surgery is inferior to open surgery. Another interesting point is maybe we could select some patients, and we select by cone. Those patients without a cone, a major difference. And here it seems that those patients having a cone before the radical hysterectomy, there is no difference, hazard ratio of 0.27. However, remember, exploratory analysis, the trial was not powered to define this difference. And it's interesting when we look where does the recurrences occur. And you see a major difference. You see much more carcinomatosis. You see much more recurrences in the pelvis and also multiple locations. So you see the real severe recurrences by doing a minimal invasive surgery. And many trials or many analysis has been performed, retrospective analysis giving us some maybe exploratory analysis. Here, for example, Luis Shiva published the Sukkot trial, and he looked on some possibilities to make some protective maneuvers, for example, by closing the vagina, as we have done when we performed the Schauter procedure. And indeed, it seems this could be something. So if you have this microinvasive surgery with a protective colpectomy, then it's the same as an open procedure. That's interesting, but we have to ask whether we should change our behavior only on such retrospective analysis. So in the end of the day, we can say this first factor we should ask for is not the case. What could be other factors? Maybe when we have less complications, that's nice for patients, but Andreas Obermeier published very clearly the data from the LAAC trial. There is no difference. So minimal invasive surgery has almost the same grade and extent of intraoperative or postoperative adverse effects. Also, this does not compete. Maybe better quality of life. We always dream that by having only 5 holes instead of 1 incision, the quality of life of patients is much better. But when we look, and this has been published by Michael Fromowitz in The Lancet, the quality of life analysis of the LAAC trial, it was similar, no major difference. So by doing a radical hysterectomy by a laparoscopic approach, the patient does not feel better after the surgery. So again, no positive finding. So what is a good reason to do then? Maybe because we are heroes and feel really cool when we can perform a minimal invasive surgery, that's really nice. And we have a lot of fun by doing such a procedure. And we feel very good. It's going to be able to do this procedure. So coming to end, why should we do a minimal invasive radical hysterectomy? Actually, patients undergoing have no benefit. Higher probability to die, higher probability to recur, no better quality of life, no reduced complication rate, and only exploratory analysis in subgroups suggest there could be subgroups with equivalency, like those undergoing a cone, those without a manipulator, those with a closure of the vagina, maybe very small tumors. But how do you recommend a microinvasive radical hysterectomy in view of all these facts? I think it's very difficult, and from my point of view, the discussion is almost beyond it. This poor guy here is Giovanni Scambia coming now, unfortunately. So, and another point is then in almost 1 month, we will hear the results of the SHAPE trial, and this will obviously end the story of also the radical hysterectomy in the small tumors could be, and we have to listen to this presentation. So finally, coming to end, I think this is for the moment the end of the minimal invasive story in cervical cancer. However, we know that there are some ongoing trials we have to wait for, but for the moment, I would not recommend for patients with cervical cancer a laparoscopic procedure. Thank you very much.
Christian, I think you really did an excellent job of raising the pressure here. So the more you talked, from my perspective, this auditorium, it looked more and more like a Colosseum. Okay? And who better to survive in the arena of a Colosseum than Professor Scambia from Rome? So please.
So thank you very much for the invitation, and it's not an easy situation, but I'm used to, because generally I am on the wrong side. When we do this kind of debates, I am pro IPEC, I am pro minimal invasive, so it's always on the wrong side, but it's okay. So let's see if I can convince you that there is still some place and some space for minimal invasive surgery. If I can have my slides.
I can open your PowerPoint. Christian, what did you do to the technical team?
That's typical minimal invasive.
If I have my, let's see.
Maybe in the meantime, as long as we wait, I would like to introduce to you Professor Moorlam, also from Charité, who will join us in the discussion later. And I think many of you have seen him in the morning. We did a great surgical procedure. So he will join us later on in the discussion when we discuss the both presentations. Looking good. So even the bribe money from Austria couldn't keep Professor Scambia from the presentation. So please.
So these are my declaration of interest. You see, there are many companies with devices, but I think that my main conflict of interest is to have been the president of the European Society of Gynecological Endoscopy. But so I will try to do my best to show you that minimal invasive surgery in cervical cancer can have still a role, and we can use it in early stage, locally advanced in some cases, and recurrence of disease. But as far as minimal invasives, this is the topics I would like to discuss with you, and in many cases you will see the same slides that Christian showed you. Just to remember, before the LAAC trial, we were all of us convinced that minimal invasive surgery could be used safely in cervical cancer, and this was based on several retrospective studies. Then we had the LAAC trial, very important trial, and you already know the results. And after the LAAC trial, the reactions were different kind of reaction. The first one was to try to find any kind of bias to this trial. But I think this is not the right way to look to any trial. What happened is that the minimal invasive radical hysterectomy fell dramatically in the world, and this was mainly in academic center compared to non-academic ones. This is what happened in our center, and you see that we completely changed. We moved to laparotomy, and laparoscopy was no more used almost at all, and the 17% of robotic procedures are because we entered into the LAAC trial. Then we had two meta-analyses, and I think that the right reaction to LAAC trial is to try to understand why this happened. And we had two meta-analyses, and both confirmed the data of the LAAC trial. One of these meta-analyses, however, showed that in tumors less than 2 centimeters, minimal invasive surgery probably could be used. This is our experience in Rome, and you clearly see that the difference in our hands was in patients with tumors bigger than 2 centimeters. Unfortunately, this has not been confirmed by the updated results of the LAAC trial, because you see that even in patients with small tumors, although they do not reach the possibility to calculate an hazard ratio, there is a clear difference between these two groups. What is important also is the quality of the surgery we do, and this is an analysis we did in our series showing that there is a clear learning curve in minimal invasive surgery, and there is a clear difference among an expert surgeon and a non-expert surgeon in the survival results. Then we had the most important consideration, which starts with this international SUCCOR study, in which it is clear evident that we have a strong impact of the peritoneal exposure to the tumor. This has been confirmed in this international trial, and this is also our clear experience in Rome. If you do not expose the peritoneal to the tumor, the results are, at least in small tumors, the same than with minimal invasive surgery compared to open surgery. So peritoneal exposure is very, very important. And it's very important to perform some protective maneuvers. This is a large series coming from the Keller group, clearly showing that when you utilize the vaginal manchette, the results are similar to the open arm of the LAAC trial. This is our experience with the conization, and it is clear that, at least in our hands, that if you perform conization and you have clear margins, you can do, at least in our center, minimal invasive surgery with safety. And this has been in some way confirmed by the updated results of the LAAC trial. You can see that the difference between minimal invasive surgery and open surgery is in patients with no conization, while when you do a conization, the results are perfectly the same. So look what we have to do until we get the results of the randomized trial. If you look to the recommendation of the different society, you see that there is a clear indication to counsel individual patients. And this is important to understand what we mean about that. And this is also very clear in the new ESGO guidelines presented by David Sibula, in which it is clear that you can use minimal invasive surgery for lymphnodal staging, and this is important because you can avoid hysterectomy in some cases. So this is why I feel that every procedure in cervical cancer could be at least could start with minimal invasive surgery in order to check the lymph nodes and avoid unuseful laparotomies. But also in these guidelines, it is clear that what we have to do. So if patient agrees, after comprehensive discussion about current evidence. So the problem is how we counsel our patient and what we can say to our patient. And this is why I think that conization has an important role in this situation, because you can have a protective maneuver, and you can also get all the data that could be useful to counsel the patients, the lymphovascular space involvement, the stromal infiltration, the tumor size, histology, grade, and you can in some way tailor radicality. So this is, to my vision, the summary that we can do on this topic. We can use minimal invasive for microinvasive cervical cancer. We can we can propose to patients with tumors less than 2 centimeters minimal invasive surgery, and this is based on by using protective maneuvers, avoid uterine manipulator, and identification of low-risk cases. You cannot use minimal invasive surgery in patients with tumors bigger than 2 centimeters. Now, what could be the perspectives in this field? First of all, waiting for randomized clinical trials. We have the RAC trial ongoing, and this will complete the accrual in December of this year. We have the ROC trial in the United States. We have this Chinese study which completed the accrual in December last year. And we have 3 more studies which will complete the accrual at the end of the next year. So we will have enough data to confirm or not confirm the LAAC trial data. But I think that what is more important is that we have to do translational studies in order to better characterize these tumors. And this is what we and other groups are doing by radiomics, which, you know, I just to remember to you, radiomics means that from an image you can get much more information than the image itself, but you can characterize the tumor, have data on the biology of the tumor, on the prognosis of the tumor. This is what we are doing, and several groups are doing this. And you see that by using radiomics, you can get a lot of information about the tumor. That means parametrial invasion, depth of stromal infiltration, lymph nodal metastasis. So this could be, to my vision, the future in cervical cancer. And this is the study that we added to the LAAC trial, in which we will perform radiomics in all these patients. And I think that the future probably will be, in order to choose the kind of surgery we want to do, to combine data that could come from the conization, data that could come from the radiomic analysis of the tumor. In this way, you can probably better characterize the tumor, and you can tailor surgery, and you can choose what kind of surgery you have to do. Finally, just 2 words about the other uses that minimal invasive surgery can have in cervical cancer. In locally advanced disease, it could be, we will still have many doubts about the role of staging para-aortic lymphadenectomy, and so we will have this study, a randomized trial, in which we will check whether or not the para-aortic lymphadenectomy could be useful to better treat these patients. But more important to me is the possibility to perform safely minimal invasive surgery after neoadjuvant chemotherapy or any kind of neoadjuvant therapy. Why I think this is important? Because I think that the future, in an era in which precision medicine will become probably the way we will treat patients, and we will have more and more targeted therapies, useful probably also in an adjuvant setting, the combination of precision medicine and precision surgery by robotic minimal invasive surgery could be probably the best in the future. Finally, we can also utilize minimal invasive surgery for recurrent or persistent disease. This is our experience in Rome with pelvic exenteration by minimal invasive surgery. It can be safely done. These are the indications that we can have for this in this situation. And we know, this is a propensity-matched survival analysis that we did, that if we select patients, minimal invasive surgery can be used to perform exenteration with the same results of open surgery. You can also do very complex procedures like the endopelvic resection procedures, also by minimal invasive disease. But what I advise, I think that every procedure in the advanced disease should start by laparoscopy, because we know that at least 10% of patients that in which we would like to do exenteration may have aborted the procedures because of peritoneal disease. So laparoscopy is the only way to check this before laparotomy. So what are my conclusions? I think that minimal invasive surgery may potentially be of great benefits in terms of perioperative morbidity. I think that if you ask to any patients, what would you like to be operated, by minimal invasive surgery or by a big laparotomy? I think that every patient will say by minimal invasive surgery if the results are the same. Second point, what about LAAC trial helped to me surgeons to rethink and reevaluate minimal invasive surgery in surgical oncology, remembering to all of us that new technologies must be tested with prospective trials. So this is the main lesson to me by the LAAC trial. And I think that the LAAC trial should represent a push toward the future, not a step back to the past. So the surgery will go to minimal invasive surgery. This is the future. So we have to understand why, in this case, this did not happen. At present, while we wait for randomized trials, I think that minimal invasive surgery can be used by expert minimal invasive oncological surgeon in high volume centers without adequate counseling to perform lymph node assessment in low-risk tumors, and I think that ongoing translational studies would allow a better tailoring of surgery. So thank you very much. But it was not easy to try to convince somebody, at least one, that minimal invasive surgery.
Professor Scambia, thank you so much for this great presentation.